This mini lecture will focus specifically on the exemplar of chronic pulmonary obstructive disease, or COPD. The second exemplar is chronic obstructive pulmonary disease, or COPD. So COPD is a slowly progressive respiratory disease of airflow obstruction. Okay? There are two types, emphysema and chronic bronchitis. And these are two distinct diseases, but some people can have both. It is preventable. If you don't smoke and you aren't around pollution, you can prevent it. But once you have it, it will never be reversed, right? So if you stop smoking, it can get better, but it's never fully reversible. It is treatable, but you can have acute exacerbations of this chronic disease and where it gets worse over a period of time. It does involve not only the airways, but also the parenchyma, which are the alveoli and the bronchioles. So what happens in COPD is people smoke. That smoke is noxious to the lungs, which causes inflammation that damages the tissues, and then scar tissue forms, resulting in narrowing of your air passages, which decreases that elastic recoil, that compliance of the lungs. That then causes thickening in the blood vessels that feed the lungs, which causes hypertrophy of the muscles and hypertrophy of the blood vessels that are feeding those lungs. Risk factors for COPD include smoking. Smoking is the important risk factor for COPD. Cigarette smoking is the number one risk factor. You can also have occupational exposure, any kind of exposure to toxins, like if somebody were to work in a coal mine factory or someplace where there's a lot of toxins that is in the air. Air pollution, genetic abnormalities, there's a alpha-1 deficiency, and as people age, you're more likely to develop COPD. So a person with COPD will have three primary symptoms. They will have a chronic cough, they will have sputum production, and dyspnea. With emphysema, you will see weight loss and a barrel chest, and with chronic bronchitis, there is a lot of sputum produced. So remember, COPD is irreversible. So once you have it, you can't get rid of it. So a big management piece is not smoking at all, but if you do smoke, making sure that you get them in a smoking cessation program, because if they continue to smoke, the disease worsens quicker. Reducing risk factors, again, getting them away from the environmental toxins. We have medications that we will use for COPD that will promote gas exchange by minimizing the secretions or handling the cough and dilating the bronchioles to promote that gas exchange. Supplemental oxygen therapy. A lot of times people with COPD are on home oxygen. We encourage people with COPD to get both the pneumococcal and the influenza vaccine because they are at more risk for these viruses and bacteria. Pulmonary rehab. So this is, we talked about in the main gas exchange lecture, the chest physiotherapy, the pursed lip breathing, the diaphragmatic breathing, managing exacerbations of the illness, and of course, good nutrition and good exercise with some activity pacing if need be. So chronic bronchitis is diagnosed when The patient has cough and sputum production for at least 3 months for 2 consecutive years. It's worse in the wintertime. And what happens pathophysiologically is that the cilia that normally in a normal person help keeps stuff from getting into the lungs, the cilia is reduced. They don't function as well. The bronchial walls thicken, and there's a lot of mucus produced that can plug the airway. The alveoli become damaged, they become more stiff, or what's called fibrosed, and then on top of that, the alveoli that have the macrophages, that their whole job is to eat up the microorganisms or foreign bodies that are in the body, they become damaged, so they don't get rid of the foreign bodies or the microorganisms and make the patient more susceptible to respiratory infection. With emphysema, which is that other distinct type of COPD, you have abnormal distension of the air sacs beyond the terminal bronchiole. So the alveoli are destroyed. The walls of the alveoli are destroyed. The surface area of those alveoli are decreased, and you have more dead space in the lungs. Remember, the dead space is where there's no gas exchange taking place because those alveoli are destroyed, and it impairs that gas exchange, and the patient becomes hypoxic. So this increases the pressure inside the pulmonary artery because the blood is flowing in there, but nothing's happening to the gas exchange. So that subsequently causes right side of the heart to pump harder. And if you work a muscle more, it gets bigger, and the right side of the heart fails, and this is called cor pulmonale. So I just thought it might be helpful to see the two chronic bronchitis and emphysema side by side. It's the same information in the previous slides with the same diagrams, but I thought it might be helpful to see the two side by side when you compare it. So these are the two distinct disease processes of chronic obstructive pulmonary disease. We've talked about this patient teaching earlier on in this lecture. The activity pacing, make sure they know, although we want to encourage them to exercise, right? These people have issues with their gas exchange and they have limited capacities, so they need to take rests during their activities. They need to use those breathing exercises, the pursed lip, the leaning forward, supplemental oxygen, eating healthy, the coping measures having to do with the anxiety, and then eventually, again, because it is not reversible, they could benefit from palliative care. These next two slides are diagrams or pictures to compare chronic bronchitis with emphysema. They used to be called, chronic bronchitis was called the blue bloater, and emphysema was called the pink puffer. We no longer use these terms, but I think that a picture can describe it a little bit better or different in some terms. So the next two pictures depict the difference between the two COPD conditions. There's two pictures here on this slide. The one on the left is showing you comparing the normal chest versus the barrel chest that you will see in a patient that has COPD, and it measures the AP diameter versus the transverse diameter. You're going to learn this in health assessment. On the right-hand side, I've shown you a picture of a person that is trying to compensate by leaning forward. They use those accessory muscles to breathe. They are, because of the chest is barrel formed, it's a barrel chest because of the chronic hyperinflation. So in order to promote that gas exchange and promote better oxygenation, these patients typically will posture this way on their own, but if not, you can teach them to lean forward to try to expand their chest cavity a bit to promote the oxygenation. So the goal of our nursing interventions is to improve their breathing pattern, to improve activity, tolerance, and achieve airway clearance. So these are some things that are going to hopefully help them get to that goal. Um, they need to know that we need to teach them that if they start having increased sputum production or change in color of their sputum, if it becomes more thick, if they have increased work of breathing or chest tightness, fatigue, if they have more coughing, fevers, chills, these would be times to seek assistance from their healthcare provider. Some of these other interventions we talked about on the earlier slides, as far as stopping smoking, we're using some pulmonary rehab, making sure that you monitor their respiratory status. Again, auscultating their lungs, checking out their work of breathing, making sure you're counting their respiratory rate, looking at their pulse oximetry, and then the medications that are going to be ordered for clients that have COPD are those bronchodilators, an inhaler, MDI patient education, that's your multi-dose, meter-dosed inhaler, and typically that's going to be a bronchodilator, albuterol type, and supplemental oxygen. Someone that has problems with gas exchange or oxygenation, specifically pneumonia as well, is going, or again, the exemplar of pneumonia, they're going to have these other interrelated concepts become issues, right? So remember, we talked somebody with pneumonia may have a hard time with activity, that's mobility. They may be tired, fatigue. We talked about they may not want to eat. Nutrition, if they're having a hard time breathing, dyspnea, shortness of breath, they're going to have anxiety. The acid-base balance we haven't gotten into yet, but that has to do with their fluids and their electrolytes, and then perfusion. Somebody that there's a two-way error there, right? So in order for the oxygen to get delivered to the tissues, you have to have that good perfusion to the body.